Hello everyone, my name is Elena Callisto. I am an Italian emergency physician. Last year had the great chance and honor to work with the MERGE group at the Royal Infirmary of Edinburgh. Today I have a few minutes to show you the results of a study about the clinical effectiveness of the STUMBL score for the management of ED patients with blunt chest trauma compared to clinical evaluation alone. First of all, why blunt chest trauma? Because it accounts for around 15% of all emergency department trauma presentation worldwide, and currently no evidence-based guideline exists unless the patient has immediate life-threatening injuries. And we all know from our clinical practice that patients frequently develop delayed respiratory complications, and clinical symptoms in ED are not considered an accurate predictor of outcome. The STUMBL score was first proposed by Battle et al. In 2014, and it is composed of 5 different variables: age, number of rib fractures, pre-injury anticoagulants, chronic lung disease, and oxygen saturation levels. This is a very interesting new score because it's the first one proposed in literature, including clinical variables, pre-injury anticoagulants, and chronic lung disease. Battle et al. Proposed 2 different cutoff points, 11 for admission to ward and 26 for admission to critical care unit. Today, we'll concentrate on the 11th cutoff point. We know that a score to be useful in clinical practice should be superior to that of the instructive clinical judgment. Therefore, this was our research question. Does the STUMBL score perform better than clinical evaluation alone? We conducted a single-center retrospective core study over a 6-month period, and we included all adult patients with an ED discharge diagnosis of blunt chest trauma. Patients were excluded if they had sustained any immediate life-threatening injury, if they required critical care admission for other injuries, or in 6 patients because of missing identification data. Clinical judgment, STUMBL score, and complications were described and compared using ROC curves and sensitivity analysis. A few information regarding data collection. Chronic lung disease was defined as the presence of chronic active pulmonary disease, and the number of rib fractures was assigned based on the formal radiology report of the best available imaging. CT was performed in around a quarter of the patients, and in around a quarter of the patients, no imaging was performed. In that case, a score of 0 was assigned. All the patients who didn't perform any imaging were discharged, with only 1 patient reattending due to ongoing pain, and he was later discharged again. And finally, oxygen saturation data were collected based on the first room-air value, but unfortunately in 3% of the patients, this was available only on oxygen. In that case, the score was assigned based on this. 369 patients were included. The majority were discharged, and 53 patients were admitted to critical care unit. Of interest, no patient required tracheal intubation. Mean age was 56, It was definitely higher in the admitted population. In that case, the mean age was 69. The majority of the patients had isolated chest injury, and around a third of the patients had documented rib fractures. 7% were on anticoagulants, and 8% had a past medical history of chronic lung disease. What about complications? These were the complications which were included in our study. LRTI and consolidation and imaging, contusion or infection were definitely the most common ones. A few patients developed pneumothorax and hemothorax, and unfortunately 5 patients died in the first 30 days after admission. The mean STUMBL score was 9.3, and this slide shows the correlation between the STUMBL score and the risk of complications. As you can see, the higher was the STUMBL score, the higher was the probability of complications. Finally, we have almost finished. Does a STUMBL score more of equal than 11 perform better than clinical evaluation alone for predicted complications? No, at least it didn't in our population. As shown in this slide, a D clinical judgment had a higher sensitivity, specificity, positive predictive value, and negative predictive value compared to the STUMBL score. As we discussed at the beginning of the presentation, a big problem in the management of these patients is the frequent onset of delayed respiratory complications. We were interested in to know if the STUMBL score could be useful for predicting specifically LRTI. But again, a D clinical judgment was equal or superior in terms of sensitivity, specificity, positive predictive value, and negative predictive value. In conclusion, admitting everyone with a STUMBL score more of equal than 11 would have led to more patients being admitted with less complications. This is a single-center retrospective study, therefore it has many limitations, it's not conclusive, and it was conducted in a large teaching hospital where junior doctors are well supervised by senior emergency physicians. The results could have been different in a setting with less experienced physicians. The STUMBL score is a very interesting new score, but further research should be done before it should be routinely adopted in clinical practice. Thank you very much for your attention.